So adaptive radiotherapy, as we all might be knowing it, is actively uses the clinical practice across the multiple organs sites to manage changes in patient anatomy and function during treatment, as conventional static plans may underdose tumor or overdose organs. This might be due to patient weight loss, organ motion, which introduce the geometric uncertainties, and daily setup errors affects the dose distributions. So adaptive RT allows the modification of the treatment plan to account for changes in target and normal organs, maybe size, shape, function, and response. Patient contours, basically based on the weight, and ultimately with the goal of accurately delivering dose to minimize normal tissue exposure and maximize dose to the target. Adaptive RT basically modifies the treatment plans during the course of radiotherapy itself. So it compensates for anatomical, biological, and positional changes, enhances the precision of radiation delivery, reduces unnecessary radiation of healthy tissues, and it's commonly applied in head and neck, lung, prostate, and pelvic tumors. So we must know the adaptive RT workflow. Basically, it is a similar for few steps, such as initial simulation and contouring, daily image acquisition, assessment of anatomical changes, recontouring, and replanning if required, and of course, the QA verification before treatment delivery. At present, it's categorized in three categories: offline adaptation, online adaptation, and real-time adaptation. So offline adaptation, as we all know, it's plan modified between the treatment sessions. Online adaptation has, is done, plan is adjusted immediately before the treatment. And last one is the real-time adaptation. It continuous imaging during the radiation delivery, such as gating and all. So the selection of a particular time scale for adaptive RT depends on the clinical goal, available technology, and resources available. Each of these implementation has advantages and disadvantages. First, we'll discuss about the offline adaptive RT. Offline ART being performed generally during the time between the fractions. It allows a more conventional treatment planning workflow and set of tools to be employed even in compressed time frame. Basic advantage of adaptive RT offline ART is that its imaging such as quantum CT and MRI may be used. Even a conventional CT or MRI on a simulator or a diagnostic scanner used as the basis of the planning. And offline ART, it allows the clinical tools. It doesn't need basically the extra tools for the RT procedures. So it's least requirement of our specialized tools. And offline ART is not suitable if the frequency of anatomical changes is high. For example, changes occur within a fraction or frequently between the fractions. It could induce rather than the correct geometric error. So next step is one step ahead is the online adaptive RT. An adaptation procedure performed just before delivering a fraction is called online ART. It follows a contemporary adaptive workflow as opposed to classical offline workflow where plan modification must be carried out under time pressure while the patient is on the treatment table and waiting for the irradiation. A well-optimized workflow and coordination of the team responsible for adaptation are of paramount interest for such procedures. And third one is the real-time adaptive RT. Real-time adaptive RT refers to adaptation during the actual dose delivery, modifying beam parameters intrafractionally without operator intervention in response to dynamic changes in the target volume positions. These changes are mostly driven by the respiratory motion, and so there are two main variants of the real-time adaptation. First one is dynamic tumor tracking, which is performed by CyberKnife and RadioExact machines. Another one is physiological gating using 4D MR image sequences acquired during irradiation, which is compatible with the MR-Linux. So if we talk about the slight difference, or we can just have an illustration of this online versus offline. So online ART is replanning during the treatment sessions. Online adaptation requires rapid optimization, and MR Linux, of course, they can give a real time. So it's basically a trade-off between speed and the accuracy. So this is an illustrative picture about the conventional plan of line ART, online ART. As we can see, the black arrows, first one is the conventional planning, that image, plan, QA, and then, of course, it's going to the treat. But if you talk about the online adaptive RT, then we have a procedure of red arrows which says the time scale of minutes, but the purple arrows have a repetition of entire workflow over multiple treatment days. So, which is of much more importance. And in case of offline adaptive RT, what we do basically, we take the image, we treat, and then access, replan, and QA. So for the time scale is of hours to days, but for the conventional planning, conventional treatment delivery, basically it's the days ones. So the offline and online ART workflows differ in time and between the process. So black arrows in the traditional planning process represents a time scale of days. Purple arrows represents the repetition of entire flow over multiple treatments. So it has a very good reference. It has been taken from a publication in Seminar on Radiation Oncology. So basically, if you talk about the physics of radiation dose and deposition in ART, it has all few basic steps similar, but heterogeneity corrections are critical and accurate modeling is required for adaptive dose recalculation, and that may be the voxel by voxel calculations. So standard treatment planning systems, what happens? Standard treatment planning systems can be employed for offline ART, but online ART requires a highly integrated specialized systems due to compressed timeline. So replanning tools integrated to the treatment delivery units may also reduce the quality assurance burdens, as it can reduce the need to send and receive data between different systems. So if you talk about the dose calculation algorithms, it's basic three. We know that Benzel beam, collapse cone, and Monte Carlo. And out of these, Monte Carlo provides the highest accuracy in heterogeneous tissues. It's an adaptive RT requires rapid and repeated dose computations. So Monte Carlo becomes more important in that case. If you talk about the IGRT procedures, its daily image verifies the patient position. Cone beam CT is widely used for this purpose. MRI provides superior soft tissue visualization. PET enables the biological adaptations, and imaging data used for adaptive replanning. For the cone beam CT, it uses the kilovoltage X-ray with flatbed detectors. Rotational acquisition reconstructs 3D anatomy. Scatter radiation degrades the image quality. So HU calibrations is required for accurate dose calculations. Daily CBCT can only track the anatomical variations. So cone beam CT has now become the standard approach to implement image guided RT. Sorry. Okay. So now if we talk about the MRI physics in adaptive RT, it's the magnetic resonance based on proton spin behavior, superior soft tissue contrast compared to CT, no ionizing radiation exposures, magnetic field alters the secondary electron trajectories, and thus the electron return effect impacts the dose distribution. So last 2 points are more concerned in the MR guided radiotherapy or adaptive radiotherapy. So there is a short description about this electron return effect. So it's a physical phenomena that occurs when secondary electrons, which are set in motion by radiation, it exits a patient tissue and are bent back into the tissue by the strong magnetic field of MRI scanner due to the Lorentz force. During radiation therapy, the interaction of high energy photon beams with the human body releases the secondary electron, which we all know. But in a standalone linear accelerator, these electrons travel in slightly straight line. Once we introduce the magnetic field, as we can see in these two figures, in the first one where the magnetic field is not applied, the electron escapes from the phantom. But in case where the magnetic field is applied, the electron returns back to the phantom itself. So it's basically the phantom study. So if we talk about the MRI linear system where the patient is placed within a strong static magnetic field, these charged particles are subjected to these electron return effect and Lorentz force. So if these electrons exit a high density medium like muscle or organ tissue and enter a low density medium, magnetic field causes their trajectories to curve, sending them spiraling back into the adjacent tissues, which finally gives more dose to the soft tissues. So there is a dose deposition at the tissue air interface, and this ERE creates dose heterogeneity around air cavities in case of a single beam. So dose distribution is anatomy specific, may be dependent on the air cavities and orientation with respect to the magnetic field. This effect can be countered by the multiple beams. So there's a symbolic picture for this tumor of the larynx, where we can see if it applies, if it is in non-magnetic field era, such as the conventional insulators, it has a very homogeneous type of this hotspot. But in case of this 1.5 Tesla magnetic field, we can see the hotspot is somehow disturbed, or we can say very well not equally distributed. Another major challenge in the MR guided adaptive radiotherapy, if we say, is requires the modifications in TG51 and other regulations that such as TRS 390 or other, which has to account for depth dose distribution, ion chamber response, and impact of machine design on the definition of reference conditions. Then we come to the deformable image registrations. So it aligns the anatomy across multiple imaging datasets, maps voxel to voxel anatomical changes, enable contour propagation and dose accumulation, essential for cumulative dose tracking, and this, of course, this DIR uncertainties affects the adaptive accuracy. If we talk about the dose accumulation physics, so the delivered dose differs from planned dose each fraction. Hence, dose wrapping used to map dose across the anatomies. Biological cumulative dose estimation improves the adaptation. Fraction by fraction analysis supports replanning decisions. So accurate accumulation is ultimately dependent upon the accurate or robust deformable image registration. So if we can see, it's a pictorial representation of dose accumulation workflow to map and some fractionation deliveries of artists. So first is the reference planning image, then fraction dose daily image, then deformable image registration daily to reference image, deformed fraction dose reference image, and sum of all fractions. So this way we have to think about it. There's a editorial published in this Journal of Clinical Applied Medical Physics in 2024, which is talking about it, which has the points and counterpoints about the deformable dose accumulation for adaptive radiotherapy practices. So if I read, it says one of the unaddressed questions regarding adaptive radiotherapy is whether the fractional adapted dose should be accumulated voxel by voxel through deformation to document the final dose submission. By accurately summing dose from the different treatment sessions, deformable dose accumulations helps in maintaining optimal dose delivery and ensures that both maximum and volumetric dose constraints are respected. However, as we already discussed, that inaccuracies in deformable image registrations may lead to the errors in dose accumulations. Now, the motion management in adaptive radiotherapy, you can see that respiratory motion affects the thoracic tumors, swallowing and tongue motion affects the head and neck cases. Motion increases planning target margins. 4D CT captures motion over respiratory cycle, gating and tracking and reduces the motion under uncertainty. So what happens basically during conventional external beam radiotherapy, patient is positioned to suit a static plan. Now, CBCT exhibits intrinsic limitations due to the suboptimal image quality. So, use of CBCT for managing specific uncertainties such as tumor motion is not established. Hence, the 4D CT imaging physics it combines the temporal and spatial image information, correlates anatomy with breathing cycle, generates phase resolved data sets used for internal target volume definitions and improves motion adaptive planning. This is a small summary about this MR Linac technology that integrates MRI scanner with linear accelerators. What is of more important is here is magnetic field influence the electron transport, as we already discussed, that electron return effect, and it requires the specialized dosimetric modelings. So MR guided RT enables adaptation of the plan optimized dose coverage for the actual patient's anatomy of the day. Hence, superb soft tissue contrast of MRI. With MR Linux in and in-room MRI scanners allows dose-free extended imaging directly before or during treatment for online adaptive RT. So for low field pre-beam imaging is usually performed using 3D imaging protocols relying on stacked 2D slices that is balanced each 3D state-free precision sequence. And for higher magnetic field MRI scanners, we go for the 3D spoiled gradient echo sequences. So this is a typical difference between the imaging of this 1.5 Tesla and this 0.35 Tesla. In adaptive MR guided radiotherapy workflow, first we take the MRI scanner and then pre-treatment CT are used for delineations, pseudo CT, and then auto planning is done for independent calculations, then position verification, and finally the treatment is done. Especially for the MR Linux, there are adaptive workflow has two basic workflows. One is adapt to position and adapt to shape. So the options range from the workflow, where the daily plan is adapted by a rigid shift based on the online patient positioning. And another one is adapt to shape, which is daily plan is fully re-optimized with manually updated delineations on daily imaging. So adaptive position workflow has basically on online patient position, fusion through, it has a rigid registration and the recalculations or reoptimizations of pre-treatment plans. It uses the pre-treatment CT and contours. It only changes the isocenter for translational shift. And it is best suited for stable anatomy where the tumor and organs at risk have not significantly deformed. If you talk about the adapt to shape workflow, it is based on the new patient anatomy, daily MR image, fusion through deformable image registrations, reconfiguration accessory, average electron density assigned for respective structures, recalculated or reoptimized, and based on pre-treatment planning objectives. So this is basically the comparison of online adaptive strategies for magnetic resonance guided prostate radiation therapy published in 2025. This is the figure from that particular publication only, that it says adopt to shape, the total time is of around 40 minutes, because first three steps are common, such as reference plan, it acquires the daily image, translation only registrations. But once we go to adopt to shape, we have to go uh, deformable image registration plus contour mapping, then manual contour edits, then inverse optimization, and then finally we are ready for the execution of the treatment. But in case of adopt to position, the total time takes hardly 20 minutes, which is because we are going optimization based on isocentership. And then finally, we are ready for the execution of the treatment. So the time interval between daily imaging and treatment delivery in adopt to shape workflow is prolonged. Hence, there has been a in between workflow has been defined, or we can say designed, but I don't know how much it is in practice. It's adopt to rotation workflow to balance the speed and accuracy which corrects for the translations and rotations of the target. Finally, we are in quality assurance in adaptive RT, verification of recalculated plans, machine QA and imaging QA, dosimetric verifications using phantoms, gamma analysis for dose comparisons, and if we can do the biological adaptation, that will be exactly true, because we are treating with the biological entities finally. So if we can convert the same adaptation to biological adaptation, that will be a great feature for us. That is, functional imaging identifies the hypoxic reasons, those planting targets, resistance, tumor areas, and diffusion MRI supports the biological adaptive RT. Personalized treatment based on tumor response, emerging area of precision radiotherapy. So what are the current challenges in adaptive RT? Basically, computational burden, time constraints during online replanning, uncertainties in image registration, resource intensive workflow, and it needs more and more automation and AI integrations. So to conclude, I can say adaptive RT combines imaging, dosimetry, and treatment physics. The physics principles ensures accurate dose adaptations. Adaptive RT improves tumor control while minimizing toxicity. Adaptive imaging and AI will shape the future of the radiotherapy. So again, future directions may be AI-driven auto-segmentations, real-time dose tracking, adaptive proton therapy, biological guided radiotherapy, fully autonomous adaptive workflow. These are few publications connected with this adaptive RT. This is the recent one published in 2025's proof of concept of fully automated adaptive workflow for head and neck radiotherapy treatments with a conventional linear accelerator. Finally, before giving a thank you, any sufficiently advanced technology is indistinguishable from the magic. Thank you.
Thank you, Dr. Anoop, for your excellent presentation. Participant, if you have any questions, please post in the chat group. If not, I have a few queries on behalf of early career medical physics. Dr.
Mm-hmm.
Anoop? Yeah.
Yeah.
How MR based dose calculations are generally managed, because CT is the source of electron density. So
Mm-hmm.
you may use CT directly for the dose calculation. In this case of
Mm-hmm.
MR based system, MR based planning, how these
Mm-hmm.
MR images are used for dose calculation?
Actually, what current technology is providing to us that we can convert these MR images into the synthetic cities, and then we can have used those cities for the further calculations. But I don't know, because I'm not the user of these machines, so how much they are accurate about this dose computations.
Okay, so you are telling that the bulk density assignment on the MR based images are being used for dose calculation, and this
Yeah,
bulk density assignment is based on the data taken from the CT, right?
yeah.
Okay, thank you. And one more thing is that the DAR images, that is deformable image registration for adaptive radiotherapy,
Hmm.
and you have told that that play a vital role in adaptive radiotherapy purpose.
Yeah.
And these DAR images can be directly used for dose calculation, or it will be used as a guide for planning the
No, this can be
replanning.
used only as a guide only. It
Okay.
can not be directly used for the, because ultimately we are doing, we are fusing those MR images with the CT only. So calculation will be done only on the CT images.
Okay. There is one more question, that is ATS and ATP. Tell
Yeah.
Dr. Akhtar, do we have time, or will keep everything at the end of this whole session?
Yeah, I think in the end of the session, we can discuss all of the questions regarding this presentation.
So thank you very much.
Thank you, Dr. Anoop, for your wonderful presentation. Now
Thank you.
we will move on to the second lecture from Dr. Prasad Pandey. He is also one of the important medical physicists in India. He secured his PhD from physics in Barkatullah University and the Department from Bark. He is also a recipient of multiple national and international awards that includes Meritorious Medical Physicist Award and Dr. M.S. Agarwal Young Investigator Award from AMPI. He has vast clinical experience in gamma knife radiosurgery and HDR brachytherapy, also LINAC commissioning. Moreover, he has teaching experience across MD radiotherapy, PhD medical physics students, and many more allied health programs. So, with this expertise, he is going to present on another topic on adaptive radiotherapy, and taking us little deeper into the adaptive radiotherapy platform. I request Dr. Pandey to share your screen and proceed your presentation. Thank you.
Thank you, Dr. Rafic, for introduction. I would like to thank whole AFOMP team for giving me this opportunity to give my lecture on the adaptive radiotherapy. So Professor Anoop sir has already told about the basic physics of radiotherapy, and to take that sequence further, so I will be talking on the adaptive radiotherapy workflow and the challenges. So I have shared my screen. If it is visible to everyone.
Yeah,
It's visible.
yeah, please.
Okay.
Yeah.
Can go ahead.
Okay, so let me start. Well, so already a previous speaker has told about the what is adaptive radiotherapy. It is basically when there is a change in the radiation treatment plan delivered to the change in, because there will be change in the patient's anatomy with the due course of the treatment while the patient is undergoing for the radiotherapy. So the new planning is required every time, which is known as the adaptive radiotherapy. So that will be the best possible suited for that particular fraction. Now, in order to account for the my screen is there or it's gone? Is it visible?
Yes, it's visible. Please proceed.
Well, so now, in order to account for the temporal changes in the anatomy, like tumor shrinkage, internal motion, so we need to have ART. So let's see the evolution of adaptive radiotherapy. So in the clinics earlier, consultants were performing the offline ART. So what happens is when the patient is coming to the clinic, and then when clinician notes that there is a change in the weight of the patient, so they re-simulate the whole thing, and then the replanning will be done, and the new plan will be given for the treatment on the machine. So this was the offline ART, and then mid-treatment replanning concept came, where after few fraction, like after 10th fraction, the again replanning was done for the patient, because we don't have much technology so to assess the when after the CBCT came into the picture and its advancement in the algorithm. So CBCT based online ART has came into the picture, and now we know about the MR guided ART already practiced in the many centers. So this is the pictorial representation, like what is the workflow of adaptive radiotherapy. So first, the simulation scan will be done. Once the simulation will be done, the contouring will be performed by the radiation oncologist. Once the contouring will be finalized, then the planning will be done by the medical physicist, and then after having the final plan with the target optimization, a final plan will be approved by the oncologist, and then the QA will be performed. Then the patient will be taken for the treatment. So this is the basic process in which the patient is undergoing for the radiation therapy. So what happened is during the treatment, the imaging is done. So during imaging, when the oncologist find that there is a change in the shape or the volume of the patient, so the oncologist take the take the decision that the patient needs to undergo for the adaptive radiotherapy. So adaptive radiotherapy, as already told in the previous lecture, that it is of two types: offline adaptive radiotherapy and the online adaptive radiotherapy. In case of offline adaptive radiotherapy, so few days are required because the resimulation, the whole procedure needs to be resimulated. And in the online adaptive radiotherapy, the patient will be on the couch, and the pressure is on the whole team of oncology to make the treatment as quickly as possible with the least uncertainties. So this is the pictorial representation. So there is a pre-planning stage like CT simulation, then the contouring and the treatment plan, as I have told in the previous slide. Then the QA is performed. Once the patient-specific QA is passed, and then the treatment will be done. So in case of ART, online CBCT will be done. If after getting the CBCT, find there is a change in the contour, or there is a requirement of editing the contour because there is a shrinkage in the volume. So the contouring editing will be done. Then the online planning will be performed. Then the QA calculation will be done. And then the treatment delivery is done. During the course of treatment delivery also, the QA measurement will be performed through the Diagnodocs files. So the basic workflow is again the patient setup, CBCT acquisition, then the rigid or deformable rigid registration will be performed based on the case to case. Structure propagation and editing will be done by the radiation oncologist, like whichever is the best possible editing one can do as per the reference plan. Then the plan adaptation will be done, like whether it is ATP based or ATS based. And then the second is just like patient specific QA, and then the delivery will be performed. So this is the basic adaptive radiotherapy workflow. So what we do in the CBCT imaging, so basically in CBCT, we have got a KV source, which is orthogonal to the MVB. The flank panel detector is there. The whole acquisition is done in the 360 gantry rotation way. And in the Linux, the FDK reconstruction algorithm was the standard industry standards were used. So on how this FDK working principle is useful in the CBCT acquisition. A CBCT machine captures basically a multiple individual 2D pictures as it's rotate around the patient's body. So what happens is the acquisition is done. Once the 2D images acquisition is done, then the filtration process will be applied. So particular filter will be applied to the acquired images, and these mathematical filters basically sharpen and it will remove the blurring. Then after this, the back projection of all these filter images will be done so that the 3D picture of the acquired 2D images can be obtained, which is blur free. So this algorithm has got very good efficiency and the speed, and it has got very good 3D adaptability. Like standard 2D X-ray reconstruction cannot accurately account for the cone-shaped X-ray beam, but here in the FDK algorithm, it adapts traditional 2D methods uh, quite precisely. And practicality, if we look, so because it doesn't require immense computing power, so it is mostly used full in the CBCT systems. So what was its limitation? If we talk about the limitation, so while FDK is excellent for routine scans, it struggles if the cone beam's angle becomes too wide. So in these cases, it can produce slight blurring or cone beam artifacts on the outer edges of the image. For highly complex cases, some advanced systems use longer, more resource, heavy iterative reconstruction tool to fix this. So after FDK algorithm, we feel that there is a lot of limitations with this, although it is accurate and fast, and hence it was used. So, but because with the advancement of the time, the requirement of the more accuracy achievement, we move towards the iterative reconstruction tool. So iterative reconstruction tool was also introduced in the CBCT, and we find that it's although it is a time taking, but it gives the very good result. So if we see the differences between the earlier used FDK analytical based algorithm and the iterative reconstruction based CBCT algorithm. So in FDK, it is basically one-way process was there. Data was captured, filtration was performed, and then when the filtration was done, blurring and other artifacts were removed, then finally the 2D images was compressed into the 3D images, and finally we got the 3D image. But in case of iterative reconstruction, the loop process was followed. So it was not simple one-way process. So the cycle of this loop will be continuous till we get this very good similarity index. So it will go again and again. So it is basically a time-consuming process was there. FDK has a limited noise handling capacity, but in iterative reconstruction, it is superior in handling the noise. Beam artifact at edges was observed in case of FDK, and in iterative reconstruction, significantly reduced artifacts were seen. Moderate soft tissue contrast were seen in FDK, but in iterative reconstruction, excellent contrast, better HU consistency. So the speed was only few seconds, and in case of iterative reconstruction, the GPU was required because of the basic principle it follows of the iteration. So large number of iterations it required to achieve the good similarity index. So in case of the latest smart intelligent LINAC machines like Ethos is there, and then Electa Evo is there. So these kind of LINACs which are properly doing the online ART, that hypersite and IBCT CBCT reconstruction algorithm is used. So what is the key features of it? It has got a very high speed hypersite, which is used in the Ethos. It has very good X-ray scatter correction. Noise reduction is very good, and it has got very high HU accuracy. So if you see, this is the picture CBCT picture acquired from the Ethos or LINAC. So here we can see how the CBCT images are taken. So once the images are captured, then with the reference city, the registration is required. So registration can be of two types. Earlier, I had also shown in the slides, it could be either rigid or deformable registration. So based on case to case, the clinician can have the choice to select like what kind of registration they wanted to have. If there is a like a lot of struggle they are feeling, so better to go for the deformable rigid registration. And if the case is not complicated enough, so they can directly go for the rigid one. The rigid has got 6 degrees of freedom with no shape change facility. But in case of the deformable registration, so voxel voice mapping will be there. It will take time, and it captures anatomical deformation, and the computationally it is intensive. So what happened in case of deformable image registration? So the reference fixed image we have got already from the CT simulator. So once we capture the CBCT of the patient in an on the particular day, so what happened is the objective function is created from the fixed image, and the optimization loop will try to uh, go with the iteration, applying the transformation model and the deformation vector field, so that it can match with the similarity index or to achieve the objective function. So once it is achieved, so at that particular moment of time, the deformable image registration will be completed. Otherwise, that iteration process will be continued. So these kind of values usually we are getting if we are using the deformable image registration. So it maps planning CT and daily CBCT. It generates a deformable vector field. So in the tumor, so all the whole set of image is divided into a set of voxel. So tumor voxel will be there, and then bladder voxel will be there. So the DVF vector, if it is giving the value of 2 mm, comma -1 mm and 0 mm, it means, so it is basically the direction in which direction you need to move, so that you will get the appropriate uh, registration. Then in order to achieve better matching, the synthetic CT generation method was also utilized. So in case of MR Linac, we know that there is a generation of the synthetic CT. So what happened is we have got the reference image, and the synthetic CT is generated from the captured image of MR, and then uh, based on the reference imaging, the the plan of the day, automatic planning will be done, and then the new plan will be given for the treatment. So this is basically AI-based CBCT to CT conversion. So we are in a AI era where the machines are also getting intelligent, and the whole radiotherapy system is now driven by the AI algorithms. So what are the primary influencers in this? So typically the high contrast or high motion organs. So motion is one of the problem over there, like in case of bladder, rectum, prostate, bowel. So these are the moving organs. So motion issues will be there. So the AI models like deep learning segmentation models were used in order to rectify this kind of influencers. So, and the deformable image registration is used for the remaining targets and the OARs. So only for the moving organs, we are using the AI models, and for others, only simple DIR is used. Now, what happens is when the CBCT is acquired and the registration part is done, then then if we feel that there is a requirement of the change in the contouring, so in this picture it is shown, the right side the reference CT is there, and here is the acquired CBCT. So uh, we do the contour editing. So what happens is the AI intelligent system, it automatically do the segmentation based on the data it has from the reference CT. And if the clinician feels like the system has done perfectly, then it can go ahead with that. Otherwise, after reviewing, if the clinician feels like there is a requirement of the change in the, so the oncologist will make the editing of it, and the tool is provided in the system. So with that, the editing will be performed and the contour will be finalized. So once it is done, then the next step of plan selection, like ATP or ATS, what kind of plan will be done for that particular case. So ATP is basically adapt to position in which no contour edit was done. So if the patient is not properly positioned, so basically the position has changed. So here the same plan, the same reference plan will be applied and nothing will be done. So it is only with the position, the plan will be adapted. And in case if there is a change in the shape of the volume, where there is a weight loss in the patient, so again a new plan is required to be generated with the full re-optimization, so that all your constants will be achieved. So when it is being done, so the adaptive shape algorithm, adaptive shape planning selection will be done, and it will be utilized for the treatment of the patient. So so in this window you can see there is a dotted line and the hard line. So in the dotted one is the reference plan and the hard one is the adapted plan. So it should be matched as close as possible. So once the adapted plan is closed with the re-optimization, so afterwards it is being reviewed by the oncologist along with medical physicist, and when it is being approved, then the plan can be utilized for the treatment of the patient after successful. Okay. After successful QA, patient-specific QA. So once the plan approval is done, then the patient will be undergoing for the QA. So the software, Mobius software is available in Ethos kind of machine, where the patient-specific QA will be done on the couch. So what happens is the data is transferred to the software Mobius 3D. The dose calculation will be done over there. So it will show you all the parameters like we were earlier doing patient-specific QA 3D, 3%, 3 mm. So all those plan information, target coverage, DVH, limits, everything will be shown in the Mobius file. So Mobius has all the information regarding your initial plan, the adapted plan, and it will take the adapted new plan data. It will again recalculate everything and give you the value of the gamma indexing. And once the plan is also delivered, so the Mobius affects what if it will use the trajectory log files, and it will compute the dose, and it will compare to the reference plan that was with the delivered one. So it ensures that the whatever the new plan you have done, so it is matching with the delivered one. So this kind of window you will see in the system. So in the Mobius Adapt software, so it will check with the green, like all the targets have achieved, the DVH limits is achieved, and the 3D gamma, the passing rates, 3%, 3 mm, that is also achieved. So here 99.9% gamma passing we have achieved in this prostate case. So this kind of report will be generated, and once the medical physicist is confident enough that the patient's specific QA is passed, now the patient can undergo for the treatment. So what happened is, since there is a deformation during the course of treatment, the deformation takes place, which is the term what used here. So as the patient anatomy changes, the voxel position changes. So the estimation of the proper dose is very much important here. So here we utilize the concept of the deformable vector field. So what happens is all the session or the fractional dose which is warped means deformed. So via a deformable vector field, it is taken care. It mapped it with the reference CT, and the cumulative dose summation will be done. So what is DVF? So it plays a very vital role. A DVF is basically a deformable vector field. It's a mathematical map created by deformable image registration. It describes how every voxel 3D pixel in one image moves to its corresponding location in another image as the patient anatomy changes. So for each treatment fraction, a daily CBCT is acquired. A DVF is generated between the planning CT and the daily anatomy. The dose delivered on that day's anatomy is deformed back to a common reference anatomy. The deformed doses from all the fraction are summed to obtain the accumulated dose. So by this, we are able to get the accurate accumulated dose in a deformed image. So voxel by voxel, basically, it is taking care of the deformed dose. So it will map the ward dose onto the planning CT. So the total dose will be the summation of the dose received in the individual fraction. So if the dose calculation is appropriate, it will improve your biological assessment, and it detects underdosing of tumor, detects underdosing of OARs, trigger adaptive replanning, optimize treatment outcomes. So what are the uncertainties sources observed in adaptive radiotherapy? So basically it is the image noise, registration errors, contour variability, HU inaccuracy, and the dose calculation algorithm limitation. So first part I have completed, that is the workflow part of adaptive radiotherapy, like how the workflow is there. So starting from the simulation, then the patient planning will be there. Then once the patient planning is there, then once it is approved, patient specific QA will be done. Patient will be taken for the treatment on the couch. So CBCT will be performed. After taking CBCT, the image registration will be done with the reference CT. If we'll feel there is a change in the shape, we'll go for the contour editing. If contour editing is done and your oncologist is satisfied with that, so we will go with the new planning, replanning, which is ATS based. And then when the new planning will be done and it is planning will be approved, so and it achieves all the targets. So when it is got approved, so it will go for the patient specific QA with the available software. And when it is being done, so the patient will be taken for the treatment. So these were the workflow of ART. And now we'll look for the challenges and the uncertainty in the adaptive radiotherapy. So only I am limited up to the CBCT based adaptive radiotherapy. So what are the primary challenges of ART? So first is the workflow delays and the time constraints. Online ART requires acquiring new images. Either it could be CBCT or MRI. So segmentation of the organs is required, re-optimization of the treatment plan while the patient is immobilized on the treatment. So the process will take around 15 to 30 to 40 minutes. So now it depends from clinic to clinic. So now auto segmentation. So manual contouring of tumors and OAS takes too long for same day adaptation. So it requires AI-based auto segmentation. Now with the new machines, Ethos kind of machine and Electa Evo, Radiotherapy. So they have got all AI-based auto segmentation tools. So now it is quick. Third one is the image quality and the synthetic CT errors. Systems relying heavily on daily CBCT struggle with inferior image quality due to scatter and artifacts. So generating accurate synthetic CT for dose calculation from these images introduces potential errors that must be safely vetted. Fourth one is the deformable image registration. So when you are performing the deformable image registration, then during registration, the error is introduced. So accurately tracking how much a tumor shrinks or how a bladder bowel fills requires mapping the original plan's anatomy to the day's anatomy. So DIR algorithms carry known uncertainties which directly impact the precision of dose warping and accumulation over multiple fractions. So finally, all these errors contributes towards the change towards the final dose calculation. So you need to have you need to follow the stringent quality assurance workflow if you are using a surface guided RT kind of tool. So in the task group 3 EG302, it is mentioned. So in conventional radiotherapy, what we assume anatomy during treatment is same as anatomy during simulation. So dose calculation uncertainty is dominated by beam modeling over there. But in the era of adaptive radiotherapy, this assumption is collapsed. So here, what happened is the dose of the day accuracy is now depending on the imaging rather than on the beam model. So the entire adaptive radiotherapy workflow depends on the physical fidelity of the imaging system used for replanning. Therefore, the central physics question becomes how accurately can we reconstruct the patient's attenuation map in real time under clinical constraints of dose, speed, and motion. Everything that follows auto-segmentation, deformable registration, dose recalculation is downstream of that imaging fidelity. So the state-of-art KV IGRT machine, which is available in the market now. So variant ethos is there, Electa Evo is there, Accurate Radizact is there. So they are the CT-based adaptive radiotherapy. It gives high quality daily imaging, rapid recontouring possibility is there, rapid replanning, because all are AI driven. Plan review quickly can be done, and the quality assurance also can be done, like the software, Mobius kind of software is available into the system. So generating a new plan with every fraction is resource intensive and time sensitive. Therefore, workflow efficiency and the clinical resource allocation are key elements. So if you see the summary of minimum requirements to consider for ART workflow, so basically two components are there. One is the imaging component, second is the image. So in imaging component, it is basically a HU accuracy should be there. So each element actually contributes towards the potential changes in the dose to the target and or the OR. So geometric integrity should be there, low contrast resolution should be high, uh, and the FOV artifacts. So ART planning image shall be free of artifacts in clinically useful field of view. And what potential clinical potential it will show? It may obscure relevant anatomy, delineation accuracy, and adversely impacted dose calculation. So finally, the dose calculation will be impacted if all these components will not be the prescribed tolerance limit. In case of image component, the deformable registration is one of the element which the suggested minimum requirement is the visual assessment. You could done point-wise registration error or mean distance to agreement within magnitude of maximum voxel dimension. So for that, the vector deformable vector concept has came so that the dose wrapping can be mitigated. So here in this pictorial presentation, we can see in this picture how the scatter is coming when we have captured the CT. So the basic challenges in CBCT for radiotherapy is scatter, then the geometric limitation, field of view. So what happens, superior, inferior field of view, sometimes it is cut if the large field of view is required. Cone beam, geometry including increased effect of scatter radiation, acquisition trajectory in time and space. So while acquiring the whole CBCT images in time and space, there will be some motion in the organ, and it leads to further introduction of the error. So this is also one of the challenge. So that is the question motion. Now the detector characteristics. So if your detector is quite good, quite accurate, it will give you the better result. So in order to overcome challenges in CBCT, what kind of solutions we have? So improving uniformity at detector plane. So first, the instrumentation part needs to be fixed. Second, for the scatter reduction, we need to look for the hardware-based solution and the software-based solution. Then improving image uniformity, improving field of view limitation, and reducing extraneous imaging dose. So how can we account for scatter? So now based on the Monte Carlo software, the scatter estimation softwares are developed, and that is successfully tried in the clinics where it will be able to account for the scatter correction. So there are publications which shows it for the estimation of the scatter, it has played a vital role. So it can be introduced and utilized in the clinics. So in the machines, variant machines, this methodology is utilized. So several broad categories like across CTS. So this is also second tool for mitigating the scatter. Motion leads to different types of artifacts in CBCT. So it leads to the blurring and the streaking, and the potential methods to reduce effects of motion. So you could use the breath hold technique. So when you are utilizing, you could see in the coming slides, when you are utilizing the concept of the breath hold, so lot of changes in the image quality you can observe. So with the free breathing and with breath hold, there is a lot of difference. The good sharpened image you will see if patient you are going for the breath hold imaging, and your system needs to have a faster acquisition time. So more time if you'll spend, then the chances of uncertainty and the acquisition of the scatter will be more. So the probability for reducing the probability, the scanning time needs to be more faster. So I have already told the breath hold technique one can utilize, and so it will be showing you with the better results. So you can have the good target visualization, image, sharp image you can have. So here I have only taken the ethos part, like how they are doing. It is doing adaptive radiotherapy. So it is using the HyperSight software utilized in the CBCT for adaptive radiotherapy. So if we'll compare the HyperSight which is used in ethos Linux with that of the conventional CBCT, so uh, what we can see is the reconstruction type of algorithm which is used is iterative here in HyperSight, and in conventional CBCT it is filter back projection. Scatter modeling is integrated already in the algorithm, but in conventional CBCT, the pre-correction was required, and sometimes in earlier Linux it was ignored. Again, so the spectrum was also one of the issue, because we don't have we have this spectrum from the X-rays. So the spectrum aware correction is also available in HyperSight, but the empirical correction was taken care in the conventional CBCT. So in order to reduce the noise, the Poisson statistics was used in HyperSight, and it was not there in the conventional CBCT. HU accuracy was quite moderate in HyperSight available today, and in conventional CBCT it was poor. HU consistency was quite high, and in case of conventional CBCT it was less. So the reconstruction speed was quite fast, and here in conventional CBCT also it was fast, and the optimized for segmentation, DIR, and Acros, and here CBCT was only for the restriction purpose. So here we can see the standard CBCT from the ethos and the breath hold ethos. So how the breath hold basically improves your mitigating the artifacts. So AI-based solutions are there for the scatter removal. So one is that software is Iris. So this is used in Electa EVO system. So what it is, basically it is AI-driven solution. It has a high definition, and it is useful in the scatter correction and for the reconstruction. So radically, it improves contrast for visualization of the target boundaries and nearby healthy tissues. It helps in the synthetic free imaging and improved HU accuracy. So Iris is used by the Electa. So Iris uses a trained neural network to predict scatter in each X-ray frame in real time. Instead of physically separating scatter before reconstruction, the AI predicts and subtracts scatter based on learned patterns from the many examples. So this is the software utilizing AI. It will predict and it will remove the noise. So we will see the example. So the conventional CBCT, this kind of CBCT was there in Iris when it has taken with the help of the Iris software. So you see the quality, you can see the quality difference. So it is far better. Then the polyquant CT reconstruction model is also there, which also uses the AI, and AI scatter correction model is used here. So polyquant CT is an algorithm using CT image to determine material mass and electron density for radiation therapy planning. So instead of assuming a simple linear attenuation model, the polyquant algorithm models how a spectrum of energies attenuate differently through tissues and quantifies their effect iteratively. It fits a physics-based forward model to the measured angles to reduce artifact and produce quantitative values. So it will improve the accuracy. So it is enabled adaptive radiotherapy. You will see it is quite better. So Iris and polyquant is used in the Electa Evo, and the variant ethos hypersite model is used. Okay. So let's summarize it. So CT-based adaptive radiotherapy. So the summary is daily imaging, recontouring, replanning, review, QS. So this is the clinical workflow that we have seen in our course of lecture. So image quality governs adaptation accuracy, geometric fidelity, low contrast resolution, uniformity, and HU stability. These are the limitation parts. So conventional CBCT constraints or online ART, scatter artifact, limited field of view, HU uncertainty. So these are the limitations that has to be taken care. And fan beam KVCT improves offline adaptation confidence, spectral imaging, quantitative electron density, and stopping power mapping. So it will further image, gives you the better imaging, and reduces the uncertainty. Thank you very much. Okay, thank you.
Pandey. Thank you so much. Thank you for your wonderful presentation. You really took us deep into the different modalities for CBCT, CBCT reconstruction, and the advancement in the CBCT based adaptive radiotherapy, and what are the drawbacks in the existing CBCT reconstruction method for performing the CBCT based adaptive radiotherapy. All are covered in your presentation. This any queries, any doubts from the audience? Please post it in the group chat. We will be keeping all these questions at the end of the final session and make it as a small panel to discuss everything. Dr. Akhtar, shall we proceed with the next session, or we'll give time for a few questions?
I think we can move forward for the next speaker, and then we can discuss.
Okay. Next speaker.
You can introduce the next speaker and continue, please.
Yeah. Next speaker is Dr. Neha Yadav. She is a clinical medical physics coordinator of Department of Radiotherapy and Diagnostics in Apollo Medics Super Specialty Hospitals, Lucknow, and she completed her PhD in radiation physics from Amity University and a DPAPI from BARC. She has 10 years of experience in this field and have expertise in SBRT and advanced treatment planning techniques and TPS commissioning and patient-specific QA. She has over more than 11 national and international publications, and she also has developed an anthropomorphic female pelvic phantom for cervical cancer dosimetry. I welcome Dr. Neha Yadav to take us to the last session on the adaptive radiotherapy and move on to the presentation. Dr. Neha, please.
Yes. Am I audible to you, sir?
Yes.
Am I audible? Okay.
Yes.
Thank you so much, Dr. Rafic. And thank you so much, Dr. Rafic and Dr. Akhtar, Dr. Atul, and Dr. Marijon ma'am for giving me these opportunities to share my knowledge on this platform. I just want to share my PPT. Now, is it fine? Is it visible to everyone?
Yes, you
Hello.
can go ahead.
Okay, thank you so much. So, first of all, very good afternoon and good morning, everyone. I'm Dr. Neha Yadav. Today, I'll discuss adaptive radiotherapy or radiation therapy, that is ART, which including its principle, techniques, clinical applications, and the future perspective. So basically, the line of presentations of this PPT, the definition of the adaptive radiotherapy and why it is needed, different types of ART, adaptive workflow and the technologies, clinical indications of ART, review clinical case example, and the future developments in the adaptive treatment. So when the idea of basically the adaptations comes from the nature itself. The term adaptive comes from the Latin words adapter. It means to fit. Just as a living system continuously adapt to changes, so radiotherapy must adapt to change in patient's anatomy and the tumor characteristics during the treatment sessions. So when we talk about the evolutions of the radiotherapy, so radiotherapy has evolved from two-dimensional radiotherapy to the three-dimensional conformal radiotherapy, IMRT, IGRT, VMAT, and now the adaptive radiotherapy. So each advancement has improved treatment precision and reduced dose to the normal tissues. So why adaptive radiotherapy is why we need for the adaptive radiotherapy? So as we know, radiotherapy is not a single day process. It takes us several weeks. Many anatomical changes can occur like tumor changes, tumor shrinkage, tumor progressions, tumor necrosis, patient changes like a patient weight loss, weight gain, post-surgical changes, and the organ changes like a bladder filling, rectal filling, and the respiratory motions. So basically, these changes can cause the underdosing of the tumor coverage and overdose to the normal structures, that is, the organ at risk near to the tumor volume, and reduce the treatment effectiveness. So therefore, a CT, a single planning CT, may not accurately represent the anatomy throughout the treatment process of the patients. So, what exactly means of the adaptive radiotherapy? Basically, it is a treatment strategies in which the radiation treatment plan is modified during the treatment course based on the observed anatomical, geometric, or biological changes. The goal is fixed. Basically, the goal of our radiotherapy is to maintain accurate dose delivery while minimizing the toxicity of the patient's risk. So think of the ART as a feedback system. So imaging basically provides informations, clinicians evaluate the changes, and the treatment plans basically adjusted based on the anatomical changes. So one more main things basically IGRT and the ART. Many people basically confuse about the IGRT and the ART. The basically IGRT stand for the imaging plus positions corrections. We acquire the images before the treatment. We correct the patient positioning, and then we treat the patient without change the plan basically. But in the ART, it's basically we acquire the images, we evaluate the patient's anatomical changes, then we modify the treatment plan when it is required. So basically, ART cannot exist without IGRT. It's a very common statement. Why? Because imaging is the foundation of the adaptive radiotherapy. So when we talk about the historical development of the ART, so the concept of the basically adaptive radiotherapies proposed by the Yan et al. In 1997, and the key milestone including development of image-guided radiotherapy, and in around 2000 centuries, 20th centuries, and the routine CBCT-based adaptations around 2010, and now the introductions of the MR-based Linux system for adaptations uh, after 2017. Now present, we are know about the AI-assisted online adaptive radiotherapy. So what was once a research concept has now become a clinically relevant for everyone, for the patient's treatment. So why we need for the adaptive radiotherapy? So basically the three major uncertainties arise the need for the ART. First is the geometric variations. For example, in geometric variation, that is setup errors, organ motions, respiratory motions, and anatomical variations. Second, that is tumor shrinkage, weight loss, organ deformations. And third one is the biological variation, means the treatment response, hypoxia changes, functional imaging changes. So basically, radiotherapy, adaptive radiotherapy addresses these changes by modifying the treatment plan according to the patient. That is, it is a personalized treatment plan for the patients. Provide the improved treatment accuracy, enhancing the tumor coverage and reducing the toxicity of the normal tissues. It's a basically complete benefit for the patients. So basic principle of ART. First, this is basically a process flow in a systematic process flow. So in the first process, we acquire the new images such as a CBCT or MRI. That images register the new images with the planning image. That is a comparison with the planning images, and then evaluate the anatomical changes like tumor shrinkage, weight loss. Uh, we evaluate that changes, then recontour, re we draw the target and OR contours, generate the optimized treatment plan, then perform the quality assurance, then we deliver the adapted plan to the patients. So adaptive basically ART can be classified according to the timing. First one is the offline ART, that is the adaptations occurs between the fractions. Second is the online ART, adaptations occurs immediately before the treatment. Third is the real-time ART, adaptations occurs during treatment delivery. These are the ART based on the time scale. Another adaptive types of the classifications of adaptive radiotherapy: motion adaptive, response adaptive, time adaptive, and the biological adaptives. But each approach addresses the different clinical challenges. So will discuss about the in a brief way offline adaptive radiotherapy. So, offline adaptive is the most commonly implemented adaptive approach. Basically, adaptations performed between the treatment fractions based on the anatomical changes observed during the treatment. So basically, a repeat CT or CBCT is required after several fractions. For example, after 20 to 40 Gray in head and neck cancer, या फिर after significant patient weight loss or या फिर major tumor shrinkage, then in that condition, we go for the offline adaptive radiotherapy. So the basic principle accounts for the systematic and the progressive changes during the treatment course. So in that condition, we use the imaging modalities CT, CBCT, yeah, repeat CT simulations, MRI, yeah, the PET CT. So we can understand these things in this workflow. Basically, this diagram shows the workflow of the offline adaptive radiotherapy. First, patient undergoes CT simulations, followed by the treatment planning over the next few days. Once the planning is approved, treatment begins. During the treatment course, periodic imaging is used to monitor the anatomical changes. For example, CBCT images. Then we just the clinician basically verify the tumor shrinkage, weight loss, or organ motions. If this type of the changes are significant, then clinical decide whether it is resimulation is required or not. If the answer is yes, then a new CT is required and the new treatment is planned. Is prepared over the following days for the next basically fraction of the treatment. If the answer is no, then continue with the that particular given plan. And this assessment is repeated throughout the treatment course whenever the clinically indicated. So this is the basically offline ART workflows. And the common clinical indications in the offline ART, basically the head and neck cancer, lung cancer, cervical cancer, nasopharyngeal cancer, and the prostate cancer. These are the basically common indications for offline adaptive radiotherapy. And when we talk about the advantages of the offline, so no doubt about it, it's improved the target coverage, better OARs protections, detailed plan review possible, comprehensive QA can be performed, less time pressures compared to the online. Definitely in online, we take almost on more than on when the patient is on couch, we take almost 20 to 40 minutes. But in this case, we perform the QA as well as the plan after some few fractions basically. So what about the limitations? So cannot correct daily anatomical variations. Yes, adaptations occurs after anatomical changes have already occurred. Next, additional imaging and the planning workload. These are basically the limitation of the offline adaptive radiotherapy. Second is the online adaptive radiotherapy. So basically, these adaptations immediately perform immediately before the treatment delivery. Uses the anatomy of the same day. New plan created and delivered during the same treatment sessions. So the basic principle is the interfractions anatomical variations. It provides personalized treatment for each fractions and optimize the dose distribution based on the current anatomy. So basically, we use in this condition we use for the imaging point of view CBCT and the MRI lineage system. So this is the online ART workflow. So in this online ART, the patient first undergoes simulations and then the treatment planning. Before each sessions, basically the CBCT, if onboard imaging is performed to assess any anatomical changes. If the changes are detected, the treatment plan is adopted, re-optimized, recalculate in a real time while the patient is on the couch. So the updated plan basically plan is then delivered within up to 5 to 8 minutes. This process can be repeated uh, basically for each fraction, ensuring the precise and the personalized treatment delivery for the patients. So the common clinical indication basically online adaptation, prostate cancer. Why? Because in the prostate cancer, daily bladder and the rectum feeling changes. So that prostate position changes, pancreatic cancers that close to the sensitive organs that move daily, bladder cancer. So the bladder size and the shape vary with the urine feelings, liver tumors move with breathing patterns, oligometastatic disease, that is a high dose SBRT requires very precise imaging. So in that condition, the online ART is a very beneficial. So what the advantage of the online ART? Basically, it's daily personalized treatment plan, improve target coverage, reduce the PTV margin, enhanced OR sparing, better management of organ motions and filling variations. What about the limitations of the online ART? So definitely it increased treatment time, high staffing requirements high staff requirements, complex workflows, requires advanced hardware and the software system. And the third one is the real-time adaptive radiotherapy. So real-time adaptive represent the most advanced form of the adaptations. So adaptation performed during the radiation delivery. So continuous monitors target positions with the help of uh, tumor uh, tumor tracking RPM we use basically in our center. So dynamically modifies treatment based on motions. So basically principal intra-fractions motion we compensate, maintains beam alignment with moving target or enables a highly precise dose delivery. So its main principle is to compensate for intra-fractions motions. So source of motion basically in the real-time ART continuously monitors these motions, respirations, cardiac motion, bowel motion, and the patient's movement to adjust the treatment to maintain the precise targeting while protecting the healthy tissues. So in the real-time adaptive radiotherapy, the patient first undergoes the CT simulations and treatment planning. Basically, during treatment, continuous real-time imaging tracks. That is, we these are the basically we come. This is a compressor belt. We just compress to fix the organ positions. And during the CT simulation, we just place the RPM, that is a tumor tracking devices to track the tumor motions. And in the case of DIBH, in the case of 4DCT, we generally use the real ART. So in that, such as that breathing or organ motion, basically we use the radiation beams automatically adjust or pause to follow the tumor positions, ensuring the accurate dose delivery while protecting the nearby healthy tissue. So this adaptation basically happens instantly during the treatment, making real-time ART the most precise form of adaptive radiotherapy. So the technology basically used in this case, sign MRI, fluoroscopy, SGRT, that is SGRT basically we know the monitors the patient's surface to ensure accurate positioning and detect the movement of the patient's body. Electromagnetic tracking, tumor tracking system, the beam hole technique, that is the DIBH. So the method which used in the real time basically respiratory gating, tumor tracking, dynamic MSC adaptation, and the couch tracking. And the workflow of continuous imaging during treatment, motion detections, target localization, and the real-time adaptations that deliver the dynamic dose to the patients. So this is the basically workflow and the common clinical indication in this case: lung tumors, liver tumors, pancreatic tumors, SBRT treatment, as well as the oligometastatic lesion. So when we talk about the advantages of this real time, the highest treatment precisions, significant margin reductions, improve target coverage, reduce normal tissue irradiations. And the limitations, definitely it's a complex technology, extensive QA quality assurance requirements, high computational demand, and the limited clinical availability. So the components of adaptive radiotherapy, so successful implementations of ART require several components working together. First is the imaging, that is CT, CBCT, MRI, PET, and the image registration, that is the rigid registration and the deformable registration. Third is the treatment planning system, quality assurance, and the clinical team, radiation oncologist, medical physicists, and the radiation therapists. These are the major components which working together to for the successful implementations of ART. So we know imaging is the foundation of the adaptive radiotherapy. So there are two types of the image registration. First of all, what is the image registration? So image registration means align two or more images so that the same anatomical structures overlap accurately. For example, we may want to compare planning CT with today's CBCT, yeah, CT with the MRI, yeah, CT with the PET. So images acquired at different time points during the treatment. So accuracy of the adaptive radiotherapy depends heavily on how well these images are registered. So there are two types of the registration. First is the rigid registration, and second one is the deformable registrations. So rigid registration direct intensity match, your point match base fusions, no compensations for the motions or the patient positions. It's a 6 degree of the freedom basically. Uh, Basically, the registration works extremely well for the bony structures such as the skull, pelvis, and the spine, because bone maintain their the shape throughout the treatment. Since the skull doesn't deform, so see, that's why rigid registration provide excellent alignments. And but for the ART, that is adaptation registrations, we there is a concept behind a deformable image registration. This is the backbone of the ART, deformable image registration, that is a DIR, because registration is not suitable for the soft tissues like the prostate, bladder, liver, lungs, or head and neck tumors, because these organs change their size, positions, and shape over time. So this brings us to the deformable registrations, also called the non-rigid registration. So it is a basically techniques. It's a very complicated, consists of a matrix with huge number of unknowns. Multimodality images can be fused. So it's allow the dose and contour informations to be transferred between the images and substantially reducing the workloads. As the time scale for adaptations decreases, the computations time of deformable image registration must correspondingly decrease. So DIR is essential for contour propagations, dose accumulations, adaptive replanning, and the multimodality image fusion we need for the DIR. In this image, you can see this is the FM image. This is the rigid. Rigid means the 6 degree of the freedom translations as well as the rotations. We can proceed. It's the basically bony structure landmark image registrations. And second one is the FM registration. That is there is translation and rotational, but some kind of the scaling and shading we can also modify. But this one is the deformable image registration. That is the image is completely deformed. So what basically clinical triggers for the replanning? So definitely the weight loss. If the patient weight loss greater than the 5%, then we will continue for the ART. And the mask gap, basically when we use, definitely in the simulation, we use the head mask. If the significant mask gap appeared, then we go for the ART. Tumor shrinkage, organ displacement, or OAR dose violation. So in that conditions, we go for the replanning and the adaptive radiotherapy. Now the clinical applications. So adaptive radiotherapy in head and neck cancer. So head and neck cancer is one of the most common indications for the ART. Many centers perform the repeated CTs around 3 to 4 weeks for the treatment. So basically adapt to changes in the morphology of the tumors and the OARs, and basically the factors which provokes for the ART in the head and neck cancer. So patient weight loss, tumor response, progressions of the disease, and the parotid shifts. So in this picture, you can see at the time of the simulation the structures of the basically tumors. We can see here after 20 fractions of the radiations, you can see there is a changes. So there is a deformable changes. So in that condition, we can continue the ART. We go for the ART. So better benefits, better target coverage, reduce xerostomia, that is dryness of the mouth, better spinal cord protection, and lower dose to the parotid gland. So in that, so ART in the head and neck cancer, you can see pre-RT after 3 weeks of the treatment and after 6 weeks of the treatment, the tumor size has reduces. Second clinical cases, that is the adaptive radiotherapy in the prostate cancer. So in the prostate cancer, daily anatomical violations is mainly caused by the bladder fillings changes, rectal filling changes. These changes basically alter the prostate position. So major concern is to reduce the treatment margins, to reduce the normal tissue toxicity, and to incorporate the generic setup for the errors and applications for the predetermined setup margin. And also the individualized setup adjustment to reduce the magnitude of the setup error. So in the case you can see here for the in the CT simulations, this is at the time of this CT, the position of the prostate. You can see here, this is the rectum, filling of the rectum. But after day of treatment, you can see the prostate basically fall in the rectum area, and the condition of the rectum, you can see here, it's completely changed. So rectum filling changes and the bladder filling changes. So that's why these changes alter the prostate positions, and which affect the overdose to the prostate and underdosing to the underdosing to the prostate, that it is target area, and overdose to the OARs. And so so that's why ART we can proceed in this case and give a very significant result, and we reduce the margin and improve the target localization better, reduce the bowel dose, and as well as reduce the rectal toxicity. So in this, there is one paper in which they include that the adaptive radiotherapy, basically maximum required PTV margins can be reduced from 2.4 to the 1.7 centimeter, resulting in significantly less dose to the bowel area. So with the help of ART, we reduce the toxicity of the patient, reduce the bowel toxicity in the case of the prostate and in the case of the cervical also. So this is a very good result of good applications of the ART, we can see. So adaptive radiotherapy in the lung cancer. So lung tumors basically represent a unique challenge because they move with the respirations. So adaptive strategies basically include the 4DCT, respiratory gating, tumor tracking, as well as the IPV-based planning. So these techniques improve the dose accuracy and reduce the irradiation basically of the healthy lung. Next one is the MRI guided adaptive radiotherapy. So MR linac based radiotherapy nowadays we know. So MR based basically radiotherapy gives the superior soft tissue visualizations, daily adaptations we can perform, and it's an online ray planning facility. So this is the benefits of the MR based adaptive radiotherapy. And the advantages of improve the target accuracy, better OR sparing, reduce PTV margin, and the personalized treatment plans. Limitations: longer treatment time and high cost, as well as the limited availability. So what about the challenges of ART? So basically DIR accuracy, that is the deformable image registrations, is not always perfect. Inaccurate image registrations can lead to the contouring errors and affect the dose calculations. Second is time consuming workflow. So ART basically involves imaging, contour review, plan adaptations, quality assurance, and the plan approval and QA approval, making the treatment process longer than the conventional radiotherapy, as well as staff requirements, QA challenges is also, and the cost. The cost of ART, basically advanced imaging system, adaptive planning software, and the additional staff time make ART more expensive than the conventional radiotherapy. These are basically the challenges. So now the conclusion of this presentation. So ART basically the personalized treatment plan. It improves the target coverage, reduce dose to the OARs, and DIR is the backbone of the ART, and the MRI guided online ART is the future of the future. So thank you everyone. Thank you so much. If you have any query, any questions, please contact me on this mail ID.
Thank you, Dr. Neha, for highlighting the importance of adaptive radiotherapy and the challenges we are facing when implementing the adaptive radiation therapy, or well presented in your presentation. Now it is open for floor. Participants, please post your question in the chat box.
Yeah, Rafic, there are some questions in the chat box already. So you can
are
ask these questions, and any of the speaker, they may answer these questions. I think this is not particularly to any speaker, but that is why any speaker can respond to this.
There is one question from Anu Roy to Dr. Anoop. How will you calculate the cumulative dose calculation, since there are different streety structures? The question is, how will you calculate the cumulative dose, since there are a lot of seed structures?
Yeah, now with the help of this deformable registration and that adaptive contourings, what we can do is, that's I already told in my lecture that this is a basic challenge we have right now to calculate to sum up the voxel by voxel dosage in different cities, and that's why the deformable dose accumulation is very important. So that is the process, that is the future, I can say. As I'm not the user, so I can't comment on that much about it. If any one of the users might be doing it, then they can comment on in a better manner, I think.
I would like to add a few things about cumulative formation. Instead of deforming images based on the anatomical changes, the impact on the dose also can be deformed, and these deformed dose over time is summed up in a CT scan, and then that is daily CBCT scans, and all these doses will be taken up for the cumulative that is accumulated dose review. That is what Dr. Anoop was trying to highlight. But since he is as this is a symbol of professors that when they do not work on the particular area, they will not highlight much on the topic, and giving this answers to the one who is using it. Happy about it, Dr. Anup. Now, the second question is, if we using a real-time adaptive, then maybe it is for Dr. Pandey. Dr. Pandey, can you please turn on your video so that the participant can see you?
Yeah.
Answering, yeah. Now, if we use a real-time adaptive, then the patient still on the couch, right? So,
Right.
after the treatment planning, how we do the patient-specific QA when the patient is on the table? So that is the question from Rian.
Okay, that's very good question actually. So in my presentation, I have shown you about how the software like Mobius it is working. So it is basically used for performing the patient specific QA. So like fundamentally what we do in current status in Linux, what we do, we usually in order to perform the patient specific QA, we use the phantoms. But here as such no phantom is required, so the all the patient specific QA will be done before the treatment through online mode only. So the what software will do, so you have got a reference plan, you have got the new plan which you have modified plan, so it will try to get from this software what it will check. It will check the few plan parameters, like it will check for the target coverage is appropriate or not, OR dose constraints whether it is there or not, MU limits it will check for, so MLC leaf speed and travel. So these kind of metrics it will check, and then the gamma also. So gamma index will with the reference plan and the modified plan. So through online it will check, and when they will be all passing within the limit, so the patient will be further taken for the delivery. So during treatment also, so Mobius adapt in my presentation I had shown in the one of the slide, like before treatment, this software what it will take, it will have the data of the initial planning. Then during that during treatment, when we'll do the replanning, so with this software it will calculate the plan matrix between the reference plan and the new generated plan, and due after when the treatment is delivered, at that time the data will be captured with the files, the log files. It will be again compared whether the reference data and the delivered data, whether it is matching or not. So this is totally online based, online mode. So as such, no phantom is required here. Through software, it will be done.
So to summarize Dr. Pandey's answer, so we should not rely on secondary dose calculation method like setting up a phantom and then delivering a treatment plan and then verifying a treatment plan. So that concept no longer work here. As he pointed out that the treatment plan is evaluated, not the dose delivery. That is what he highlighted. And as a early career physicist, we may be thinking that the patient is on the table, then how the dose will be delivered. So that is what his concern may be. So, so thank you, Dr. Pandey, for highlighting such a wonderful question on this online adaptive radiotherapy. Next question may not be relevant. Maybe this is for Dr. Akhtar. It seems that will the presentation be sent to our email? So
yeah, actually, we will upload the entire recording on the AFOMP website, and participants can go and download over there, and again they can watch this video, and then they can listen to the speakers.
Then one more question on maybe Dr. Anoop and Dr. Pandey both can respond, because they highlighted this much, this ATS and the ATP workflow. And what situation the ATP works and ATS works, and why such concept is introduced in the ring gantry system, not in the C gantry system.
So, if you talk about the adopt to position, that is basically for the fixed ones, fixed, more or less a fixed target. We can use that procedure. And as far as adopt to shape is concerned, that is more important for the moving organs or moving structures, we can say, such as Dr. Neha very elaborately said in her presentations regarding that bladder and rectum and all those, prostate and all those things. So basically, the moving structures should be adopted to the shape, and the fixed structures can be more or less to go for that rigid registration and adopt to position. Only the isocenter shift is there, and the previous plan that can be worked very well. Hope I have answered this. Yeah.
Yeah, I can also add on, sir.
Yeah, sure,
Actually,
please.
yeah. So two modes we have told. So it is ATP and ATS modes. So adapt to position is basically when there is only a positional error in the CBCT images. So only the position is changed. So at that time, there will not be any requirement of the new replanning. Only with respect to the position, your reference planning will be changed. But in the case of, and no auto segmentation will be required here. So, but in case of adapt to shape, since there is change in the volume, shrinkage will be there. So because the shape has changed, so the contour editing is required. And then the full replanning with the optimization, all those things will be required. So this is the basic difference in two modes, ATP and ATS modes. And so this came because of the advancement in the technology. So earlier, when we had got a C type of Linux, at that time, no such technological advance. At that time, we have those options only available. Now, with due course of time, we have got the technological advancement, and with the help of AI, so many more softwares are now coming to the market, and we are utilizing all those facilities. So maybe later on something new will be there. So hope many more challenges can be mitigated with the time.
Dr. Neha, would you like to add anything?
Dr. Neha, please unmute yourself.
Sorry. Yes.
Yeah.
No, thank you.
Okay. So to summarize this ATS and ATP, that Dr. Pandey and Dr. Anoop highlighted that since the table correction is not possible like C gantry Linux, that we can easily translate the shift in terms of table corrections in the O gantry Linux. So these two concepts were introduced, that ATP and ATS. This will make the, instead of the table correction, the MLC adjustment can be made to deliver the treatment plan equivalent to the previously computed plan. That is what Dr. Pandey highlighting, that this advancement may in future may take into some other concept, and new things may emerge. So these are the summary of ATS and ATP workflow. Is there any other question to be posted, or we will wind up this session, Dr. Akhtar?
Yeah, I think we already, the 10 minutes is over. So if there is no questions, we can conclude by thank you all the participants, speaker and moderators, and of course the organizers, the ETC and the PRC here over here. And once again, thank you very much for your, the participation. And I would like to invite for the next bi-monthly webinar that will be held on 13th of August. And I have shared only the screen. Please, be with us for the next webinar. So thank you all. Thank you very much for your time.
Thank you, everyone.
Thank you so much.
Thank you.
Thank you. Thank you
Thank
very
you so
much.
much.
Thank you so
Yeah.
much.
Thank you.
Thank you.